Now, years ago, when I had my facial feminization surgery, as so often happens, I had to go off of hormones for a period of 2 weeks. Now, I'm not going to question the wisdom of that requirement by my surgeon, although I think we do have reason to question why there is perioperative cessation of hormones. Instead, I want to focus on the psychological and emotional distress that I experienced as a result both of my hormonal fluctuations, but also as a result of the physiological changes that occurred from going off hormones. From just that 2 weeks, I completely regressed in terms of things like breast growth and fat distribution, and in terms of erections. And it was extremely difficult for me psychologically, and it took months and months. In fact, I think it took about 6 months to regain all of the breast mass that I had lost. I was not prepared for that. I was not told about that. Instead, I was told what is generally expected in the informed consent process, both from a legal, practical, and ethical standpoint, which is I was given information to decide whether to undergo surgery, but was not given much information, as much of the information that I needed to prepare for it. So I was told things that, like the nature of the treatment, what the expected benefits were, what the material risks and side effects were, and what alternatives there were, although not many things in terms of alternatives when it comes to trans health. The standards of care generally follow these terms when they talk about surgical process and informed consent, although they also do talk about the need for adequate preparation as part of the job for mental health professionals. The jurisprudence also falls into the same pitfalls of focusing on the information to decide and not information to prepare. And indeed, oftentimes in a test for medical liability, whether or not the person would have changed their mind is part of the test for causation. So it is very much focusing on the information that is necessary to decide, with the notion of material risks and material side effects. Beyond the medical issue, beyond the legal and ethical issue of not really recognizing the importance of information to prepare, there is an inherent limit in the informed consent process that arises from the positionality of surgeons and mental health professionals. Oftentimes, these professionals are cisgender and thus have less of an intimate understanding of what trans patients experience and what they are going to care about the most. This positionality also impacts trust and comfort. Patients are oftentimes not comfortable explaining these kinds of issues to them, and oftentimes the way that surgeries are approached tends to downplay post-surgical support, because surgeons are very busy people and oftentimes don't do a lot of checkup afterwards. They check on your health, of course, your physical health, but they oftentimes don't check on your emotional health afterwards, and especially after there's been a level of distance that allowed for reflection by the patient, where the reflection could have benefited the surgeon in these terms. Similarly, mental health professionals oftentimes not involved, for the simple reason that, well, one, lack of comfort on the part of trans people, but also, and which was my case, it's expensive to go to a mental health professional, and so going there to give that kind of feedback was not a reasonable possibility for me, as it wasn't for a lot of trans people. Part of the thing also with surgeons and comfort is that oftentimes you only had a couple meetings with them prior to surgery, haven't developed a kind of kinship that would make you comfortable sharing these very intimate difficulties with them. So, I didn't tell my surgeon because I didn't want to deal with that. the kind of preparation that I needed, this kind of psychological and emotional preparation relating to incidental physiological changes, fell both outside of the expertise of surgeons and mental health professionals in many ways, and also in traditional conceptions of the informed consent process. And what I want to argue here is that we really need to recognize the necessity of what I call perioperative disclosure of information, namely disclosure of information that is necessary to prepare for the surgical process understood as a whole, regardless of whether it would or wouldn't impact the decision of the person to have surgery. I believe that in law, there is already a huge space that exists for the recognition of that sort of for the recognition of a perioperative duty to disclose in informed consent process, because from a moral and also legal standpoint, free and enlightened consent is about the person taking responsibility for the action of the surgeon and becoming the source of the action, instead of it being an imposition on my autonomy. So by consenting to surgery, the surgery becomes my choice. I become the source of the surgery as a sort of originating force. And that is extremely important here, because we can't really say that I'm the originating source of the harm and the hurt that I experienced from hormonal cessation, because I was not told about it. And I could have acted to mitigate these difficulties by, for instance, scheduling more appointments with my mental health provider ahead of time, or scheduling out of social contact, and thus, made kind of a safe, comfortable space for me to experience those difficult feelings. So that kind of ancillary decision making is cognizable in legal terms if we only, expand our mind. And while it's not yet recognized as legal duty, there's definitely a lot of legal potential for the notion of perioperative duty to disclose. And I think there's also an immense ethical potential. And what I want to do here is really invite surgeons and mental health professionals to think about these kinds of issues and to look forward on how we're going to recognize it in practice, which is, well, no one knows people's needs and desires better than the people themselves, and the informational burden can only be met by properly engaging with trans communities as creators of knowledge, and by directing funding towards community organizations who can generate knowledge about what kind of information is needed to prepare for surgery. That is part of surgeons and mental health professionals' ethical duty to promote educational and informational measures. And it's particularly important, I think, to ensure that knowledge creation reflects the needs of all trans people, and not only those who are very privileged and comfortable with telling their stories to surgeons directly.